Thank you very much, Marzin, and thanks to ISEMPH for the kind of invitation to talk to you today. I'm going to talk to you primarily as a clinician. I don't have original research to present. I'm going to give you clinical perspectives on adopting the evolutionary perspective.
Here at the back. Yep.
Here, okay. So I'm going to begin with some general principles, which there will be a degree of overlap with previous speakers, but I'll try and minimize that. Principles on the reasons for the neglect of evolution in medical education and training. I'll talk about proximate versus ultimate causation or mechanisms, evolutionary reasons for why we may become unwell, and then I will also caution against this concept of viewing diseases or disorders as adaptations. Then I'll move on to clinical implications, and I've divided that into the areas of assessment, diagnosis, treatment, and some direct treatment implications, prevention. And then I think an important point I want to emphasize is the whole notion of professional development and clinical effectiveness in us as clinicians. So on that last point, I've been playing around with some images on this AI generator over the last few weeks on how I might appear to my patients and my colleagues and how I feel because of the benefits of having an evolutionary perspective in psychiatry, okay? So if you bear with me, you go into one of these AI generators, I inputted bald doctor, okay? So that's how I appear, maybe objectively to people around. But with the evolutionary perspective, okay, I've started to think in recent years that having evolutionary perspectives are like a superpower that I have, okay? So instead, this is how I actually feel, a bald superhero doctor, okay? So I'll try and capture that in more objective terms, but that's the general gist I want to kind of convey to you. So as I say, these are general principles. First of all, reasons for the neglect of evolution in medicine and psychiatry. I won't dwell too much here except to point out the obvious that despite its central importance as a bedrock of biology, the teaching of evolution is largely neglected in undergraduate medical education, in postgraduate clinical training, and in education generally. Reasons for this neglect may include hangovers from our past when evolutionary principles were misused and misinterpreted for political or racist purposes. There may be religious objections to the teaching of evolution in various parts of the world. And at the clinical level, as we've mentioned already today, there may be a perception that evolution, while interesting, lacks clinical utility in everyday practice. I hope that in the course of this brief talk, I can convince you of the many potential benefits for clinical practice of adopting the evolutionary perspective. Another general principle is this whole area of proximate versus ultimate causation or mechanisms. The standard mainstream approach in psychiatry, as we know, is on proximate or endpoint dysfunction, particularly neurotransmitter systems such as serotonin in mood disorders or dopamine in psychosis. In contrast to that proximate approach, in mainstream psychiatry, the evolutionary perspective focuses on ultimate causation mechanisms as well, and thus broadens the focus to our long-evolved behavioural, emotional and cognitive systems that come under stress and become dysfunctional when we're mentally unwell. So the standard psychiatric perspective is that of a mechanic trying to fix a problem, whereas the evolutionary perspective also encourages us to think like engineers. What are the systems, underlying systems that have gone awry when we do become unwell? And then after pointing out this principle, I'll move on to evolutionary reasons for why we become unwell. Now, Paul mentioned, I think, 8 or 9 this morning, and he talked about the difference between lumpers and splitters. So I'm going to be the ultimate lumper by reducing it down to 3 key areas for why we may become unwell. Evolution is slow, evolution is imperfect, and evolution is not interested in our happiness. And it's obviously derived from reading Randy's book. Within the slow pace of evolution, we have this whole area of mismatch. So in contrast to the rapidity of social, cultural, and technological evolution, our biological evolution is slow, directionless, and it leads to issues with environmental mismatch. As a species, as Annie pointed out earlier on this today, we've spent perhaps 99% of our time in pre-industrial, pre-agricultural settings, living in small groups of closely related individuals, foraging for scarce food supplies in dangerous and hostile environments, and rarely meeting outsiders. So this is sometimes referred to as the EEA, or the environment of evolutionary adaptiveness, although of course there were likely many different EEA scenarios. But it was in these EEA scenarios that our current traits, characteristics and coping strategies evolved and were honed. And then organised agriculture, the development of towns and cities, industrial revolution, increasingly rapid technological, social and cultural changes of the past even half century have resulted in modern environments that are often very safe and comfortable for us, but unimaginably different from any EEA scenario, thus leading to multiple examples of mismatch, leading to stress, suffering and illness, both physical and mental. A good physical example is our primitive tastes for sugary and fatty foods, and how in our pre-agricultural environments it was adaptive maybe to binge on these food types when we could find them, whereas nowadays in many parts of the world access to such food types is cheap and limitless and leads to problems with obesity and diabetes and so on. Also under the point of the slow pace of evolution, we have our battling with microorganisms. So bacteria and viruses evolve faster than we do, and bearing in mind that reproduction is the engine that drives the pace of evolutionary change, it follows that these microorganisms are always several steps ahead of large multicellular organisms such as ourselves in the evolutionary race. So while our immune systems respond slowly to new microbial threats with tiny changes, microorganisms can produce hundreds of thousands of generations during the timescale of a single human lifetime, leading to all types of issues such as our most recent pandemic. Then we have the imperfect nature of evolution, and here we have 2 points. Firstly, there's constraints. There are some things that evolution just cannot do. So a fundamental principle of evolution, as we know, is that the process is blind, it's directionless, and there is no overarching plan or design, intelligent or otherwise. So each new generation of an organism and each new individual mutation is pitted against the prevailing environment, and the fittest individuals are selected to survive and reproduce. So while this process leads to exquisite phenomena that appear to be perfectly designed for their environment, such as, for example, the hummingbird sucking nectar from deep inside a flower, the process can also be inefficient and lead to problematic vestiges such as the human appendix, wisdom teeth, back pain and so on. The recurrent laryngeal nerve is another often cited example. Its circuitous route has no particular purpose, but evolution has no interest in fixing this so-called design flaw. Moving on then to trade-offs, certain medical conditions that are ostensibly perceived as illness may also have an adaptive flip side. So a classic example here is sickle cell disease. The heterozygous carrier state for this condition confers protection against malaria in populations living in endemic zones. Thus, while individuals with fully penetrant sickle cell disease suffer with the condition and are at risk of medical complications, the condition may persist because of the protective benefits against malaria in carrier individuals. And then finally, in terms of the lack of interest that evolution has in our happiness, evolution maximizes reproduction, not health. So evolution and natural selection are, as I've said, blind, directionless processes. Genes that are associated with traits and characteristics that lead to reproduction will be more highly represented in future generations. So evolution has no interest in our comfort or happiness. If a trait makes us deeply unhappy and stressed, but increases our reproductive potential, then it is more likely to be represented in future generations. And finally, we have defensive responses are not necessarily disorders or diseases. So this is the whole area of VSAD, or viewing symptoms as disease or disorder. So evolutionary thinking may rescue us from this whole area of VSAD, a potential error in clinical practice and in the thinking of the general public. So just as pain, fever and vomiting may have adaptive and protective benefits in combating illness and are viewed as symptoms of underlying conditions and not as primary disorders themselves, certain psychiatric symptoms such as anxiety and low mood may have adaptive benefits, especially at milder levels of severity, and should not be regarded as being necessarily pathological. And finally, in terms of general principles, we have this whole area of VDAA, viewing disorders or diseases as adaptations. So while evolutionary thinking may help us reject the error of viewing symptoms as disease, it also makes us vulnerable to this other principle, viewing diseases as adaptations. So major mental disorders that we treat in our clinical practice, such as schizophrenia, bipolar affective disorder, are unlikely to have any benefits for individual sufferers and should not therefore be viewed as adaptations. However, applying an evolutionary perspective asks the question why we as a species should continue from generation to generation to remain so vulnerable to conditions such as these, and what underlying behavioural, emotional and cognitive systems are affected when we do become unwell. So there are just some general principles, first of all, and there was a degree of overlap with previous speakers, but it's just useful, I think, to pull them together again at the end of the day. Moving on then to clinical applications or clinical implications of the evolutionary perspective. So I'll begin with assessment and diagnosis, and I'll begin with the biopsychosocial model that we're familiar with in psychiatry as described by Engel back in 1977. It has over the decades encouraged a broader view of etiology and assessment in psychiatry, but the model is, in my view, it's had its day and it now needs improvement. Viewing biological, social and psychological factors in individual silos is arbitrary and at times misleading. Furthermore, the biopsychosocial model takes little account of ontogeny, or individual development, and no account of phylogeny, or the development of traits and systems in us as a species. So as a result, Adam and Riyad and Paul have developed a very welcome EVO biopsychosocial model, which Riyad is going to present tomorrow. And then, of course, we have Randy's social review of systems, which this is an acronym that focuses on assessing an individual's social situation, their occupational status, children and family, income, appearance and abilities, and love and sex. And there's more factors to it as well. But I think it's a useful guide. Tapping into these vital domains of social functioning is essential in assessment, I think. And Alfonso Troisi's goal system also complements this further. And this acronym relates to giving less weight to subjective symptoms, observing actual behaviour, assessing functional capacities, and leaving your office to make observations. So I think these are evolution-informed principles that I think are very useful, and I find very useful on a day-to-day basis in assessing patients. Moving on to treatment. We have so how does the evolutionary perspective help us in terms of direct treatments? Well, there's at least one direct clinical application for treatment of anxiety and panic, again developed by Randy, known as the smoke detector principle. According to this model, much of the anxiety and panic that we experience are false alarms, our body alerting us to threats and dangers where there are none present. And while it's better to have an over-detective smoke detector or threat detection system than an underactive one, especially in the more dangerous EEA scenarios of our evolutionary past, anxiety and panic symptoms are, as we know, distressing and disabling. So the smoke detector principle, I believe, has great explanatory power for patients and can help people to engage with standard treatments such as cognitive behavioural therapy and medication treatments. Apart from this direct clinical application, the evolutionary perspective also, I believe, has limitless indirect applications that are likely to be of use to our patients and families, not to mention for us as treating doctors. So being able to explain to our patients the evolutionary basis for normal emotions, cognitions and behaviours, and how such systems can go awry for any of us if sufficiently stressed or traumatised, can help engagement with treatment and reduce a sense of othering for those who are unwell, ultimately leading to destigmatizing effects. The rationale for treatments is also much clearer and more persuasive with an evolutionary underpinning, and medication, I believe, prescribed by an enthusiastic doctor is likely to have a more powerful placebo effect. It should also be emphasised that evolution-informed treatment, of course, is not a replacement for standard treatment, but is instead an essential explanatory framework for what we do every day in the clinic. And then finally to prevention, again there are limitless implications when applying the evolutionary perspective to the primary prevention of mental illness. For example, evolutionary mismatch is central to the development of addictions. Our bodies and brains are not evolved to deal with the potent and toxic effects of use of distilled alcohol or synthetic drugs. And while many people may benefit physically and psychologically from moderate levels of alcohol intake, highly potent distilled alcohol has the potential to hijack our dopaminergic systems, thus leading to addictive and self-destructive behaviors. So again, I believe this perspective is destigmatizing in that it takes us away from making misguided moral judgments about people struggling with addictions. And it also raises questions about access to alcohol and substances. Along with avoidance of or minimization of novel stressors or environments such as alcohol, drugs, social isolation, social media, and so on, an increased emphasis on optimizing our modern environments and reducing environmental mismatch is also likely to lead to a whole range of evolution-informed questions and interventions aimed at enhancing social connectedness, engagement with nature, and encouraging people to healthily get out of their heads through, for example, physical activity. Obviously, we all aspire to live active and socially connected lives, and we promote such approaches in our patients. But again, an evolutionary perspective, I believe, underpinning these concepts gives them much more meaning and makes our advice to our patients much more persuasive. And then finally, we're back to the whole area of superpower and how the evolutionary perspective really enriches certainly my life as a clinician, and I think it rubs off on my patients and my colleagues. I've had a career-long interest in the area, being lucky to be introduced to the topic as a trainee, but it was always a background hobby of mine for many years until a combination of factors, including the COVID lockdowns, led me to become more immersed in the area in recent years, to collaborate with colleagues from around the world to establish our own Irish evolution and psychiatry special interest group. So I believe as a psychiatrist, we must think deeply about the human condition and human problems, and the evolutionary perspective gives us an infinitely more nuanced and comprehensive approach than current mainstream perspectives in psychiatry. I'm also a medical teacher, and I've always liked the catchy simplicity of the so-called 3 E's of being an effective teacher: expertise in one's area, enthusiasm for the topic, and empathy with the educational background of the students. So in a somewhat comparable way, adopting evolutionary perspectives in my clinical practice also makes me as a doctor more expert, more enthusiastic, and more empathic. So in recent years, I have started to think of my evolutionary perspectives as being my superpower as a psychiatrist, and it is a superpower that I want to share with my colleagues. Thank you very much.